Okay, Dr. Andrews.
Good evening. This is Dr. Jim Andrews, and I'd like to welcome you to a new webinar series created by the American Sports Medicine Institute. Building on the success of ASMI's Masterclass webinar series, this new series is entitled Sports Medicine Update and is designed to present topics of interest to primary care medicine physicians, although anyone who provides care for athletes is certainly welcome to participate. Tonight's topic is extremely timely, and we will discuss concussion management. As we all know, primary care sports medicine physicians are an integral part of the sports medicine team. I've often said that they are the glue that keeps the team together. The new webinar series was proposed by ASMI's Executive Director, Jay Vines, who has worked with me in a variety of capacities for over 35 years. Thanks, Jay, to you and the staff of ASMI for providing this opportunity to bring this important group together and learn from each other. We have a great group of speakers assembled tonight to bring you up to date on this significant problem seen in collision sports, concussions. To get us started, I'd like to introduce our moderator, Dr. Jody Ortega. Jody completed a primary care sports medicine fellowship at ASMI in year 2000, and he is now on the staff, of course, at Andrews Sports Medicine Orthopedic Center here in Birmingham. He is also the program director of ASMI's Primary Care Sports Medicine Fellowship Program. At the conclusion of tonight's final talk, we'll have a panel discussion led by Dr. Ortega. You're certainly welcome to submit questions through the Zoom chat feature, and we'll try to get to as many of your questions as possible. With that, I'm going to turn things over now to Dr. Ortega and let him introduce tonight's speakers who are well positioned to be able to talk about this particular subject as experts. Jody?
Thank you, Dr. Andrews. Just want to say welcome and to everyone here tonight. We have a great session with Dr. Tucker, Dr. Gioia, and then Andrew Hutchison, who's one of the therapists here in Birmingham. So just a few housekeeping points to start off with. We will address questions during the panel discussion at the end of the presentations. Please submit the questions for the panel using the chat feature at the bottom of the Zoom screen. And then to receive your CME or CEU certificate, please send an email to ASMI's course coordinator, Caroline May, at Caroline, CAROLINEM, as in man, at asmi.org, with your name and credentials, such as MD, ATC, PT, etc., to receive your certificate for tonight's session. Those certificates will be emailed in approximately 2 weeks. Participants other than medical doctors and athletic trainers will receive a certificate of attendance that can be presented to your profession's board to receive credit. And then please be sure to click on the link to the SurveyMonkey that will be in the email containing your certificate. Your reactions and comments will help us determine whether or not this activity has met your needs, and your comments will also provide a basis for any future improvements to our sports medicine update series. So that's all the housekeeping issues, and now I'm going to introduce our speakers. I'll just go ahead and introduce all three at first, and then they'll just follow each other through the session. So Dr. Andy Tucker is a 1990 graduate of the ASMI Primary Care Sports Medicine Fellowship Program. Before coming to Birmingham, he earned his medical degree from Southern Illinois University School of Medicine, followed by family medicine residency at Baptist Hospital in Nashville, Tennessee. Currently, he's the medical director of MedStar Union Memorial Hospital Sports Medicine, as well as the co-director of the Primary Care Sports Medicine Fellowship there. Andy's special interests include musculoskeletal injuries, evaluation of non-surgical orthopedic problems, and concussions. He also serves as the head team physician for the Baltimore Ravens and is past president of the NFL Physicians Society. After Dr. Tucker will be Dr. Gerard Gioia, who's the division chief of neuropsychology and the director of the Safe Concussion Outcome Recovery and Education Program, or known as the SCORE program, at Children's National Hospital in Washington, D.C. He also directs the Neurobehavioral Core Research Laboratories for Children's National Clinical and Translational Science Institute and the Intellectual and Developmental Disabilities Research Center Additionally, he currently serves as president of the Sports Neuropsychology Society. His special interests include disorders involving the executive functions and pediatric concussions, mild traumatic brain injury. He's been the principal investigator on several multi-site CDC-funded research studies of pediatric mild TBI with a focus on the development of methods and tools for the evaluation of the executive functions and post-concussion neuropsychological functioning, which has led to the development of several smartphone apps. The concussion recognition and response and concussion assessment and response, CareSport, the acute concussion evaluation known as ACE, ACE, and the ACE Care Plan, a pediatric neurocognitive test for concussion and post-concussion symptom scales for children and parents. He works closely with the CDC on their Heads Up concussion educational programs and is a contributing author to their toolkits. He's also the team neuropsychologist for the NHL's Washington Capitals and the NFL's Baltimore Ravens, as well as numerous school systems in the area and youth sports organizations in the Baltimore and Washington, D.C. area. And our final speaker is Andrew Hutchison, who's a physical therapist and board certified sports clinical specialist here at ATI Physical Therapy at St. Vincent's here in Birmingham. His primary focus is clinical treatment as well as teaching with the ASMI fellowship programs and clinical instructor to physical therapy students. He's a graduate of the University of St. Augustine for Health Sciences in St. Augustine, Florida. He's been practicing since 2011 and was board certified in sports physical therapy in 2014. So with that, I'll hand it off to Dr. Tucker.
Thanks, Jody. Can you hear me okay? Mic check. Got it? Good. I'm going to try to share the screen here. Jody, can you see the slides okay? Good.
Yes, we can see them.
All right, thanks, Jody. Thank you for the invitation. Thank you for the kind invitation. The only edit I would make to my background, and it's my Demon Deacon blood in me. I did my family medicine residency at Bowman Gray Baptist Hospital, but not Nashville. So another Baptist hospital. But anyway, it's hard to believe it's been 30 years since my time at ASMI and how concussion management has changed since I was on the sidelines at Shelby County High School and Liberty, or not Liberty, Livingston University, now University of West Alabama. Certainly the comprehensiveness with which we evaluate our student athletes and follow them and manage them has changed a good deal. I left Birmingham and went to the Cleveland Clinic working with Dr. Bergfeld and started working with the Browns. And then early in the 1990s, there was sort of a significant increase in concussions to prominent football players, specifically quarterbacks, which got everybody's concerned. And then soon after that, Commissioner Tagliabue started the NFL Concussion Committee, the original Concussion Committee, which was not without its controversy, which you'll say, but was certainly, I think, a great springboard to beginning to understand basic epidemiology and the biomechanics of concussion. I'm just going to provide a general overview to concussion and sort of set the table for my colleague, Dr. Joya, who's truly one of the national and international leaders from a neuropsychological point of view, and I'm fortunate to get to work with him closely. And then Andrew will finish up talking about the therapy treatment of concussion. Dr. Curtin gets a bit of a shout out here because I pilfered some of his slides from the Fellows Talk that he gave this past fall. So again, 1980s and 1990s, I think the evaluation at that time probably involved a few questions and flashing some fingers in front of the eyes. Fortunately, it's a good deal different than it is now. As you can see, sort of on the timeline, the first International Concussion Conference at Vienna was 2001, and it's followed on a very regular schedule. I know Dr. Joy has been a regular participant in all of these. Berlin was the most recent in 16. The pandemic interfered, I think, with the proper sort of rotation, but hopefully the next International Concussion Conference will occur in Paris this year. And most of us are familiar with this document. It sort of provides a significant amount of our sort of understanding of concussion and summarizes the management and summarizes some of the more controversial issues as well, which we'll touch upon a little bit later in the talk. These are some of the major considerations of the talk tonight, and we will kind of summarize what the Berlin document has taught us and has led us through the last couple of years, and we certainly look forward to sort of another round of updating of the state of the state when the Paris conference occurs later this year. As far as the mechanism of injury, certainly the classic coup contra coup mechanism has been widely taught and is understandable. I think many of our concussions are a little bit more complicated than that. Certainly rotational stresses to the brain are probably significant in contributing to the vulnerability of the actual concussion injury. As far as the definition, again, the Berlin and previous iterations would reinforce that this is a traumatic brain injury caused by mechanical forces that could happen to the head, neck, or face, or could happen indirectly from a blow to the body. It generally involves a relatively finite number of signs and symptoms that occur very quickly, although in some cases occurs more gradually over minutes to hours and perhaps even a day or two. It is, again, still largely thought of as a functional disturbance rather than a structural injury without significant abnormalities on standard neuroimaging. And the clinical course and the resolution of the problem generally occurs sort of in a sequential, fairly predictable course. However, in some cases, and some of the more difficult cases that we all face, some can take weeks or months to resolve, and we'll touch on prolonged post-concussion symptoms a little bit later in the talk. As far as pathophysiology, we don't really have time to delve into this too much, but again, a reminder that this is basically an injury at the cellular level, not a significant structural injury. So I consider the injury to be microscopic with normal conventional neuroimaging. Think of it as a metabolic injury. I think Dave Hovda was the first one I listened to at a lecture many, many years ago, who sort of helped me understand this concept of the neuronal injury followed by potassium and glutamate release from cells. The ionic imbalance requires increased energy to restore the normal ionic balance across the neurons, which sort of creates what I kind of termed a long time ago sort of a metabolic mismatch, or in this slide it's called a metabolic crisis. And the effects of this is the signs and symptoms of concussion, which can be, of course, hugely variable depending on our athlete. But over time, we've certainly understood that there are domains of dysfunction that can be sort of grouped in categories, and the slide does a nice job of sort of breaking down the four major categories or domains of dysfunction, including physical and mental, sleep dysfunction, and the emotional and behavioral domain. Moving on quickly to the evaluation piece, for those of us on the sidelines and covering games and events, sideline evaluation critically important for us, for the athletic trainers or physical therapists or whomever is on the sideline. And this has come so far in my professional lifetime compared to the early days of my days covering games as a family medicine resident or as a fellow, or even in my early years as work up in Cleveland. The numerous iterations of evaluation tools are far too many to mention. The SCAT-5 is the most sort of up-to-date version of one of the most commonly used things, and that sort of again sort of provides a nice framework for an evaluation, and we'll sort of hang our hat on that as we sort of move through the evaluation, both on the sideline, locker room considerations, and even office considerations for a concussion evaluation. Priority number one is, of course, besides do we or don't we have a concussion, is do we or don't we have something more or worrisome or other than a concussion. The SCAT-5 evaluation does a nice job of sort of highlighting sort of red flags that we all have to keep in mind or be mindful of to make sure we're not dealing with something perhaps more serious or something even different than just a straightforward concussion. The observable signs is also something that I think was added in the last iteration or two of the SCAT-5, which reminds us of some basic signs and symptoms that, if present, are almost certainly diagnostic of the injury. The Maddox questions, basic mental sort of status questions about orientation, part of our armamentarium on the sideline as well. The Glasgow Coma Scale, which was not a part of sort of the SCAT examinations early on, but has been included now more recently, and usually not something that is terribly useful or pertinent in most of our situations, but is something that has been added back or included in the SCAT evaluation. And of course, rule number one, or if not one, rule number 1A is anytime there's a head injury, we need to be completely mindful of the cervical spine and the possibility of either a coexistent C-spine injury or significant C-spine injury. And that is something that none of us should ever forget, no matter what level we're taking care of. So the red flags, again, we don't need to go through them, but again, signs or symptoms of things that might portend a significant cervical spine problem, such as bilateral or forelimb numbness or tingling or weakness, and the like. Certainly other signs and symptoms, things like a worsening headache or deteriorating mental status could indicate that we're dealing not just with a concussion, but with focal brain injury, perhaps a bleed, epidural or subdural. But again, the red flags are critically important to have at our ready, either memorized or on a card or for reference, to make sure that we are checking these off to make sure we're not missing something more worrisome than a concussion. The observable signs, again, when they're present, they're usually very diagnostic. There's something else, there's something going on that is likely to be concussive. And the Maddox questions, again, providing sort of an initial 10,000 or 20,000 foot view, I guess, from a mental status standpoint, commonly used on the sidelines and in the training room. Common questions we often get from our parents and coaches, as well as athletic trainers and medical residents and people training under us, is when to send the athlete to the emergency room. Again, the different iterations of the concussion guidelines have sort of helped summarize this in a nice way, and these are the most recent recommendations coming from the last consensus guidelines. Certainly a Glasgow Coma Scale less than 14. Loss of consciousness, a prolonged loss of consciousness is certainly still not something that I think any of us would feel very comfortable with. So a prolonged loss of consciousness of a minute or longer would almost certainly necessitate a trip to the emergency room. Short duration loss of consciousness in the absence of other worrisome signs or symptoms is certainly not necessarily something that deserves a trip to the ER. Focal neurologic findings, worsening mental status, seizure activity, and we've talked about worsening headache, all requiring not just an ER visit, but likely some urgent or emergent imaging. If the sideline examination is indeterminate or even if it's diagnostic and the athlete is not so disabled, oftentimes as part of our protocols, we will move into the locker room and provide a little bit more of a layered evaluation, including getting a little bit more information about their concussive history, if we don't already know, and hopefully we know a lot of these things already. The symptom evaluation accomplished by the standard sort of symptom scale using the 1 to 6 point Likert scale is part of things. And then comes the cognitive screening, which is in sort of a brief run through an evaluation of orientation, short-term memory, delayed recall, and concentration, in ways that most of us are well familiar with. A brief neurologic screen, including extraocular movements, and we'll talk a little bit more about that in the office screen. Balance testing, something that was sort of added to and incorporated as an important part of concussion evaluation not that many years ago, the modified BEST test, for example. And then ultimately there's a disposition. Does the patient have a concussion or do they not have a concussion, or if we're not sure? Of course, in this day and age, if the answer is 2 out of 3, if it's yes or we're unsure, the athlete, of course, is going to be withheld from play for certain, no matter what age or level of competition. SCAT-5 is also, besides giving nice guidance to the examiner about how to do the evaluation, equally important, I think, is just the basic education that goes to the patient, or in this many cases, the family, the parents, or whoever's looking after the younger athlete, and basic introductory information about treatment, which we'll talk a little bit more about right now. So again, in the early days, before we knew a whole lot about, and study had been sort of rather haphazard and not very organized, I think the typical treatment for concussion was, sort of stick them in a dark room and solitary confinement, so to speak, for a period of time. Certainly brain rest and physical rest, I would say, still is a very important part of initial concussion management, but we'll be interested to hear from both Andrew and Jerry about their perspective on sort of how things have evolved from their perspectives, and that oftentimes complete rest is sort of not necessarily fallen by the wayside, but as sort of the pendulum is swung towards perhaps early mobilization in terms of just getting the person a little bit more active sooner, both from a cognitive standpoint and maybe even so slightly from a physical standpoint, depending on the symptomatology. The principles have always been that a concussion probably will do better if we rest them, and rest them a lot in the acute phases. And while that makes probably a good sense from a number of perspectives, it's not necessarily been that easy to actually prove with regards to studies. But certainly initial rest, both from a brain and a physical standpoint, I think makes sense and is the way to go. But after a couple of days, gradual increase in activity, both from a brain standpoint and a physical standpoint, it also makes some sense. I think one of the things that has changed incredibly over the last many years in my professional career with regards to concussion is sort of seeking out things that physical therapists, people like Andrew, and also athletic trainers that are skilled in therapy can improve and treat, no different than an ankle injury, a knee injury, a back injury, a shoulder injury. We are so much more focused and attendant to things that we can help with active therapy. And we'll talk just a little bit more about that as well. And I will, of course, defer to Andrew more specifically about how he goes about it. if we talk about office exams, again, this could be considered sort of an office exam or a locker room exam. Following along symptom scores is important. Attention to cervical spine dysfunction. This picture is, of course, a cartoon of looking at occipital nerves, and we've realized over the years that occipital neuritis or neuralgia can be sort of a coexistent pathology that can create a lot of head pain and headaches, and can be treated in ways, both physical therapy and active injection, as well as cognitive and mood and sleep, vestibular and ocular assessments from a variety of ways that can be done to sort of identify and target specifically what can be done to perhaps nurse the athlete along and hasten recovery. I won't belabor these next couple of screens. Most of us are well familiar with sort of the VOMS screen. These are on YouTube if you're not familiar, but just the concept of sort of understanding the function of the extraocular movements and the dysfunction and the symptoms that can be produced, even with a simple, basically 1 or 2 minute evaluation, is very helpful. Convergence the same way. All these helpful screens by the physician and the athletic trainer to help identify dysfunctions that can be targeted by the physical therapist. And sort of going back to the concept of domains, a number of these domains sort of fall, and I think this is a slide maybe from our friend Mickey Collins in Pittsburgh and his group. You know, the concussive syndromes can oftentimes sort of fall into these categories that lend themselves to targeted treatment, and they're not always, you know, certainly in necessarily silos. A lot of times these bubbles overlap, but the recognition of dysfunction and symptomatology in each or every one of these is beneficial. As this slide sort of indicates, there are things we can do. There are things we can do to help from the ocular vestibular point of view, the cognitive point of view, the migraine point of view, targeted treatment for cervical spine dysfunction, as well as anxiety and mood. We don't have enough time to dive into the, you know, the details about what is best or what is utilized for each of these, but I just sort of marvel at the, you know, more sophistication, if that's a word we can possibly use, of both our evaluation as well as our targeting of treatments than even 15 years ago. It's been a remarkable sort of thing to watch and be a part of over the years. Talking about recovery and return to play, there are some indicators in which can be helpful to sort of figure out whether an athlete is more likely to have sort of a more conventional, typical return to play or symptom recovery timeline and return to play timeline or not. One of those symptoms, or one of the most practical things that I think we all noticed over time, and then it was borne out by the studies over the years, was just the symptom burden. Symptom burden within the first 24 to 48 hours has seemed to be a fairly reliable thing to sort of hang your hat on with respect to risk for more prolonged recovery. Other things that I think us older people have seen over the years that were borne out by the studies was that certain types of people were at higher risk for more prolonged recovery. Girls, somewhat more than boys, I would say, especially high school and college girls, maybe somewhat more at risk for prolonged recovery. Adolescents, the younger brain versus the more mature brain. And we've certainly have borne that out by the data as time has gone by. And then people with certain coexistent or pre-existent sort of comorbidities, such as anxiety and depression, and the headache syndromes certainly seem to struggle more and are more at risk for prolonged post-concussion type symptoms. Many of our athletes are diagnosed with ADHD. Certainly, and this is an area of expertise and specialty of colleague Jerry, doesn't necessarily mean that an athlete is going to take longer to recover, it seems, but certainly in the return to learn domain, these patients, these student athletes can be somewhat trickier with regards to recovery. Just real quick to blow through some of the sort of protocol and monitoring that is done by our athletic trainers or our assistants in the offices, the symptom checklist, certainly, and then it is on us to come up with sort of a reasonable return to learn or return to work sort of plan, which is sometimes some of the most time consuming but important endeavors that we can, usually working in conjunction with athletic trainers and the school administrators and the teachers, and folks like Dr. Joya can provide extremely valuable input. Return to learn protocols, which I won't belabor. I'll let Jerry perhaps touch on that either during his talk or with the, and then the return to play protocols, which are from a general point of view are similar regardless of the age of the athlete or the sport, with some exceptions depending on your sport. But the concept of going from a state where you're basically asymptomatic with your daily activities again to increasing the cognitive activity, and when that is in line, then introducing some light aerobic activity, and then some non-contact light sport-specific activity, moving on to full unrestricted drills, aerobic and weightlifting activities, and then full practice, and then back to games. Pretty much a reasonable way to go about it, regardless of the age of the athlete. Usually taking a day per stage, also very reasonable, although certainly with older athletes and older brains at the professional levels, it's possible that we may condense this return to play paradigm a little bit, but the general concepts remain the same. As an example, I just threw this slide in as an example of specificity of our sport. We take care of a lot of equestrian, the equestrian world, our Horsemen's Health care, which is run by Kelly Ryan, one of our former fellows here at MedStar Sports Medicine, giving an example of exactly what it looks like with our jockeys at Pimlico or Laurel on their return to ride, or literally getting back on the horse, I should say, and what that looks like in our equestrian world. Not going to say too much about neuropsych testing. I think Jerry's expertise, second to none. Certainly neuropsych testing is often part of what we have to accomplish, or what is recommended to accomplish on monitoring the athlete back to an assessment of return to play. The timing of which I can let Jerry talk a little bit about. Things like impact have certainly been around a long time, and I think are very helpful. There are, of course, pros and cons and strengths and weaknesses of all these different measurements and programs that are available to us. Pen and paper neuropsych tests probably more helpful to tease out some of the things that can't be easily teased out with computerized neuropsych testing, and I'll leave that for Jerry to comment upon. The concussion recovery, as those of us that have seen a lot over the years know that 1 to 2 weeks is a typical recovery trajectory, with longer times oftentimes seen in the younger athlete, and then the comorbidities oftentimes playing a role in prolonging recovery as well. I'll say just a couple of words about post-concussive syndrome. I think it's a term that it can be thrown around a lot. Perhaps it's better not to necessarily use that because of a lack of a clear definition, but certainly prolonged symptoms or persistent symptoms of concussion may be more reasonable. And when you use that terminology is generally when the athlete sort of exceeds the typical time recovery course that you would expect, taking into consideration sort of the risk factors that we've already talked about. Those that are symptomatic after many months are very challenging patients, and it's generally thought that not so much this is a prolonged effect of an uncomplicated concussion, but in my mind, it's oftentimes an activation of either a comorbid or a latent issue such as anxiety or depression or an underlying headache syndrome that is the flip, the concussion flips the switch, and it's oftentimes hard to sort of flip that switch off. The other thing that we could spend certainly an entire conference on, the concept of chronic traumatic encephalopathy, or CTE, has been somewhat controversial over the years, and that goes back to our original concussion committee with the NFL. I mean, it's my feeling that certainly there is a small subset of people that are vulnerable to sort of neuropathologic tauopathies, if you will, either based on or due to either repeated head injury without concussion, possibly repeated concussion, but the actual incidence or prevalence of this entity is certainly still something that I think we have a hard time getting our arms around, for sure. And perhaps we have a couple of minutes to talk about this more in the discussion period. Risk reduction, the last couple of minutes, I'll just talk about in the world of the NFL. They really, I think the concussion committees have really moved the manufacturers of the helmets to improve the helmets. There's a very rigorous testing program in place that I think is also probably utilized at the NCAA level, in which the research has really allowed us to have testing paradigms that really do allow us to sort of assess effectiveness of helmets and potentially decreasing concussion risk based on those performances in the laboratory. Rules and behavior modification, playing heads-up football has been a mantra for the last several years with the NFL and the NCAA, and being taught also at the lowest levels of football. You can see from some of our NCAA or from our NFL data, based on video and impact type studies, that the tackler with a lowered head, such as depicted on the slide, has probably a 2 times baseline risk of having a concussion, but the person in the red helmet who is receiving sort of that torpedo blow, if you will, from the lined up head, neck, and spine, as much as an 80-time baseline risk of sustaining concussion just based on that sort of head down striking blow as compared to playing heads up football. I'm going to stop now and turn it over to our colleagues, Jerry and Andrew, and look forward to the discussion.
You're muted, Dr. Joanne.
Okay, good. So let me replay that tape. And again, thank you for the invitation to speak tonight, talk about the role of neuropsychological testing. And as I was saying, it's nice to be back in Birmingham, at least virtually. It's been a few years. I was down giving a few talks at the Children's Hospital and its concussion program. But I'm going to talk about, again, another evolving area that's been part of this whole process. Just let me tell you, disclosure, one of the things that I learned 20 years ago is that, at least as far as what we were doing with children, we didn't have a lot of tools. And through CDC funding and some other kind of things, we developed a lot of tools, some of which actually I do receive some royalties. I'm actually not going to be talking about them today, though, in this talk. So again, I'm going to talk a little bit about, how the neuropsychologist functions and the role of our testing program in the diagnosis and management. But first, just to mention that, there are many different roles and activities and places that a neuropsychologist can operate in. As a clinician, we work in hospitals, some in private practices, some just directly with teams and leagues, others at the university level, and some actually working directly with the schools. A number of us do a fair amount of research. This is a field that has evolved and needed evolution, quite honestly. And we're really involved in evaluating and really moving into the management treatment as well, the whole process, and really working across the age spectrum. So I'm a pediatric neuropsychologist by training, but I work into the adult years, certainly with the Ravens, with the Capitals, and with university players. And we tend to deliver this, in a more traditional way, to clinics and sort of functions. It used to be that telemedicine was a novel way of delivering, and 2020 obviously changed that. But we do some of that practice through telemedicine, and then a lot of consultation. I work a lot with different schools and leagues, and really just trying to help both with the prevention side of the injury, but also helping coaches and work very closely with athletic trainers in our local schools and universities, contributing knowledge to the care of athletes. So with all of that, again, we assess cognition. That's a big part. We also play a role in the symptom assessment. I'm going to talk a little bit more about that. And of course, as we've been expanding this, many times in our clinic, we will at least screen the ocular motor imbalance issues. And as Dr. Tucker mentioned, we've been really expanding now in many respects these profiles, learning that concussion can manifest in a variety of different ways. And that it really is incumbent on all of us as clinicians to be looking at these different areas, sleep being a significant one, but so are the others as well. And of course, that then results in, how do we then plan for treatment? And as you heard Dr. Tucker talk about, that targeted treatment now, that active rehabilitation model is really critical. We just don't let kids or young adult athletes just sit around and wait for it all to end. So getting into the issue of neuropsychological testing, over the years as neuropsychologists, one of the things I'd say we are famous for is our 6 to 8 hour battery of testing, looking at every last function that might be an issue. And that was appropriate for more significant neurologic disease or disorders. If you have a severe traumatic brain injury, you can have many, many different areas of impairment. But as we've learned in studying mild traumatic brain injury, it really focuses down into several different areas that we can tap into. And as a result, a good neuropsychological testing platform is going to be more focused, more specific. And so we're interested in the speed of processing or performance. Speed from the point of view of the brain really is using much of the brain, and is a very sensitive indicator because it is employing much of the brain in terms of its efficiency. But we also know that attending to a situation and processing information in memory is also critically important and can be impaired in individuals. And then we talk about really the kind of executive functions, or the sort of the global management functions, how you kind of think and organize and sort of manage a lot of different things. And we know that these functions can also be affected by this injury. But again, this is much more specific and targeted in what we're looking at. And we can really do that in a variety of ways. And there have been a number of different reviews, including the Berlin and prior to that, the other international concussion and sport conferences that have looked at all of our tools. And as neuropsychologists, we've looked at both the paper and pencil modality, the computerized modality. I've done work with the American Academy of Neurology and with the CDC in looking at where are we with these tests and measures? What is reasonably diagnostic? What is sensitive? We started out actually with paper and pencil. And in fact, two individuals, Mark Lovell, at the time when he was working with the Pittsburgh Steelers, was doing a lot of paper and pencil testing. Chuck Noll basically said, "You're taking too long. I need my players in preseason to be out here practicing." And so Mark actually converted a number of our standard paper and pencil measures into a computerized measure known as IMPACT. Other measures came along. There was one actually through the military called ANAM. CogSport was developed over in Europe, and other measures as well. IMPACT has sort of stood the test of time, although there are some other measures that are still available. But one of the things that we have really recommended is that you have what's called a hybrid model. The computerized measures are okay. I mean, they are reasonable measures. But if you think about testing somebody memory on a computer, it's basically, do they recognize what they just saw? So a recognition memory. It's really not asking you to retrieve that information in ways that the brain really needs to. And that, again, is a bit more sensitive to these injuries. So that's why we pair together the paper and pencil measures with the computerized measures. Now, I will say that not everybody has that available to them. You may not have a local neuropsychologist or psychologist to do that. But I would certainly suggest that we do our best to try to find someone that can really bring the full package together, because I think it's far more effective. And it's, again, what we're doing in the NFL, the NHL, Major League Soccer, in rugby, in most of the professional and collegiate sports now. What we know is that there are differences based on age, based on whether you're male or female, and based on when you are tested as to what the kinds of effects you may see from that concussion on your cognition. I will say that the research literature, though, has been somewhat narrow, examining adolescents or young adult, that is, collegiate or professional players, mostly male, and mostly in that acute period. When I have somebody come in that's a 7-year-old or 9-year-old girl, and I try to apply the literature to that, I have to be a little bit careful. But nevertheless, the same principles apply here. And so what we're really looking for then is that detection of, direct cognitive effects, or even some indirect effects, as I'm going to talk about. What we know is that the best sensitivity is early on. That first week to 2 weeks is when these tests are the most sensitive. And after that, we start to see their sensitivity begin to dwindle. Some of the challenges that we need to consider here, simply doing a computer-based measure like IMPACT, where is a person starting from? What is their baseline? How do we know whether they've made significant change either in the negative, that is impaired cognition, or in the positive, that is in recovery, or are they the same as they were prior to the injury? And this really gets to the metrics of measures and really understanding that the test retest of any measure gives you the stability of that measure. And really, as I say, it's like the thermometer. When you put it in one time and you get your temperature, you put it in another time, and you want that measurement to be fairly close. You don't want it to be highly variable, because change then is difficult to assess. And our different measures are somewhat variable in this regard, but nevertheless, having an understanding of the metrics behind those measures allows us to make better evidence-based decisions. So I just sort of throw that out kind of quickly here. The other question is, how primary is the cognitive dysfunction here? We certainly know that we can have people that are very impaired with their attention, with their memory, with their speed, but we also know that other symptoms can play a role in interfering in those cognitive issues, and then it can become more of a secondary kind of issue. So accounting for fatigue, somebody who's not sleeping well, the pain of headaches, other problems with their vision, and staring at a screen, or again, somebody that has really significant decreased emotional tolerance. Dr. Tucker remembers one athlete we had a number of years ago who had a premorbid anxiety disorder, and he did very, very poorly on impact over and over and over again, to the extent that when I saw him, he told me, "I hate that test." And I said, "I get it. We're going to do something that's a little bit different here." And this is a very high achieving athlete, but again, had some secondary effects of his anxiety. So all of these things we want to be looking at here. We also focus on the exertional effects, asking somebody, to what extent have your symptoms changed after you did those cognitive demanding tests? Because that tells us another set of information as to when you put a stress on the brain cognitively, does it produce symptoms in the same way that we would do that with a physical protocol. So again, the question is, does cognition, sit along the same line as these other areas, or do we really see it also having the potential of being secondarily affected here? And this is the big decision that I have to make when I'm assessing somebody. Is it a more primary kind of factor? Is it secondary? And again, you've got to put all these things into line as you're assessing that. So again, we do this in a variety of ways, certainly professional consultation, whether it's, with the Major League Sports. Many of us work with our local universities, as well as, again, trying to translate this down to the youth level and working with moms and dads, quite honestly. As I said to my good friend, Kevin Guskowitz, at some point, you've got to be developing your athletic trainers for youth sports, because we need them on the sidelines in the same way that we have them with our good Baltimore Ravens. The other thing I just want to highlight here that Dr. Tucker mentioned is the prevention efforts. I think all of us, would love to see this injury be prevented. And as we think about the three levels, most of us deal at the secondary and tertiary prevention. That is, the injury's already happened and we're detecting it, or we're doing something to prevent it from getting worse, or to improve the quality of life of somebody who's got a persisting issue here. And I really think, a big effort now is really on that primary prevention. What can we do to teach our athletes to, again, keep their head out of the way? USA Football, which is, a group that I consult with and work with very closely, is developing the football development model that's looking at the age of the youngster and what are their physical, their cognitive, even their sort of social and emotional capabilities that say, I am targeted for this level, or I'm better off learning at another level that I'm prepared for. Probably not every 8, 9, 10-year-old is ready to get into tackle football. But the same can be, argument can be made across many sports, and soccer and hockey have really been at the forefront of looking at how you develop a better sport sort of match with that individual's skill set. And now USA Football is doing a really nice job with this. It's really a combination of medical as well as sport and athlete development experts. And I was very fortunate to be part of this process here. Another piece I will tell you about is a colleague, Eric Swartz, who is up at UMass, one of the UMasses, I can't think which one it is right now, but who's developing a helmetless tackling technique that he started actually at University of New Hampshire, and is basically teaching now high school athletes how to build that skill set without the helmet on, and then eventually when you get into competition, putting the helmet back on. But it's, again, teaching respect for the head here. So I think these are the important elements that we can be doing and recognizing and ultimately promoting, which are the prevention elements here. So I'm going to move past that there. So again, we can certainly help, because I think behavior change is ultimately a critical factor here in risk reduction. Players understanding that, by using certain methods, I can reduce my risk of injury, and I can, elongate my career. But for coaches also to incorporate in their their teaching, coaching methods, and parents reinforcing that as their kids are moving into these issues. And what we know is that the culture of our contact sports in particular, oftentimes can promote high risk activities and behaviors, and we need to kind of move around that. And so we're really working with Eric Schwartz on developing a sort of a culture change model. Let's be good and active and competitive. Let's definitely be focused on winning, but let's also make sure that we're not doing things that put us at risk here along the way. So I'm going to stop right there. I just also mentioned that our Sports Neuropsychology Society is one that really takes on many of these different issues here. We have annual conferences, including one coming up in May, and we have many different groups that attend that conference. It'll be virtual this year. Feel free to look at the website to find out about it. But again, I think that this field and certainly the role of the neuropsychologist in the field has evolved dramatically over the years, as I think you're going to hear Andrew talk about with treatment in the physical therapy world. So thanks again for listening. Let's see, do I need to turn off?
Just stop sharing your screen.
Hey, good evening, guys. As Dr. Ortega said, my name is Andrew Hutchinson, and I'm a physical therapist here in Birmingham. Thank you to Dr. Tucker and Dr. Joya. It's just an honor to be invited on this panel, and thank you to Dr. Andrews and Dr. ASMI for having the opportunity to speak here this evening. Hopefully I'm going to be able to provide a little bit of information on therapeutic interventions for concussion management. I'd like to just kind of review some initial treatment options for concussions, look at some of the discuss some treatment-based classification systems that is available to maybe stratify how these patients and athletes present, and then look at reviewing specific exercise interventions for these patients. The Berlin conference has kind of been at the moment, or for what I tend to follow, is the kind of gold standard. When I mean looking at the initial treatment, it kind of goes immediately to that injury, and then looking at the immediate evaluation, whether that's performed by the physician on the sideline or another licensed healthcare professional, such as an athletic trainer or a PT. As Dr. Tucker mentioned, a particular focus needs to be on ruling out any potential cervical spine injury, and those red flags are kind of key to follow. If, in some of our high schools and areas here in Alabama, there may not be a healthcare professional there on the sideline. Hopefully we have at least a trainer there or a therapist or someone else. But if not, then it's important to educate these schools in some of these areas that the player needs to be removed from the activity, and a kind of immediate referral to the physician. Kind of that immediate treatment should include just clearance of the airways, your classic ABCs for emergency management, your airway, breathing, and circulations. If a sideline management tool can be utilized, that's excellent as well to kind of get that immediate baseline. In addition, I think as Dr. Tucker mentioned, that the first hours are very critical after an injury. It's important for the athlete to be monitored and just make sure that there's no deterioration of status. And I think over the last several years, and I look over the last kind of 10 to 20 years of my life, both professionally and then kind of previously playing sports growing up and in high school and college, there were times that potentially the athlete got their bell rung and they immediately go back in the game. And I know there was an incident in the NFL several years ago, I believe it was with the Chargers, where an individual suffered a seizure kind of on the flight back after he had most likely suffered a concussion in the game. There was an issue with that individual going back into the game to continue to play, and then obviously some a more severe medical event occurring. So I think it's very important that if we feel that a sports-related concussion has occurred, it's kind of imperative that these athletes don't go back onto the field of play that day. As has been discussed already tonight, and I'll kind of briefly run through a little bit of the research before getting immediately into some treatment interventions. Kind of that classic cocoon therapy is kind of outdated, and you know, those initial couple days of rest, both mental and physical, is very key. But you know, from there we want to begin modifying activity and kind of controlling any symptoms of these patients, and beginning to return them hopefully back to their normal life, whether that's just getting back to school or ultimately back to the field of play. Over the last decade, beginning back in kind of 2013 and moving currently, there's been a variety of studies that have shown that you know, this controlled activity shows lower rates of ultimately post-concussive syndrome, where we can get them back within that kind of, you know, 7 to 14 days for adults, or within, you know, 3 to 4 weeks for the adolescent or youth population. And multiple studies have shown that kind of prolonged rest, greater than 1 to 2 weeks, kind of ultimately ends up prolonging these athletes' symptoms. When we look at kind of returning these athletes back to sport or just their general activities, Ellis has found, and multiple other studies have shown over the last several years, that, you know, roughly consider rest for a little bit of time, and then beginning that graded return to activity. I think it's also important to recognize that there may be state-specific regulations and kind of rules before these athletes can return to play, whether that is, I believe here in Alabama, they need to have a formal clearance from a physician. Other areas may have the athletic trainer can provide that clearance, or there may be a mandatory timeout where that athlete cannot play for, you know, 7 days, 10 days. So I think it's just important to recognize the area where we're practicing in, and then ultimately having to factor in some other considerations. Is this a you know, youth high school individual? Is this a high level college or a low level college, or is this a professional athlete? And I think, as Dr. Tucker mentioned, you know, there's some variations that can be done depending on some of their presentation and how they advance through. From the Berlin Consensus and from Catherine Schneider's PT, who's done a lot of research. Right now, I think the best research shows that the brief period of initial rest, that, you know, 1 to 2 days, maybe 2 to 3, depending on the athlete's presentation, is kind of the amount of rest that's needed. And then we want to go ahead and initiate some of that symptom-limited activity. It's important for these patients to remain kind of below their cognitive or physical exacerbation threshold. And in the coming slides, we'll discuss some of those areas briefly. But as they're able to advance through their program, it's important for them to kind of go through each step of a recovery process without recurring their symptoms. It's important for the therapist or the trainer to continue to monitor their activity levels. This may be including some cardiac assessments such as heart rate or blood pressure, monitoring the exercise duration and intensity that these athletes perform. And generally each step should take approximately, 24 hours, and it may take 5 to 7 days to kind of return to the field of play. But hopefully we're able to kind of return them back safely. And as Dr. Joy mentioned, begin looking at some areas to hopefully prevent any future concussions. If they are kind of returning through a return to sport program and symptoms do occur, we want to make sure that they drop back to an asymptomatic training level and then continue their progression. So that may incur a delay of a couple days before they're able to return to full sport, but ultimately kind of controlling their symptoms is key for kind of a safe return that I've found. And ultimately, the timeframes are going to vary depending on these athletes' kind of age, their skill level. I see differences, like some of the literature showed that Dr. Joy and Dr. Tucker mentioned, that between males and females, some age issues, and I think you can also look at, as they mentioned, some of the ADHD and some of the other kind of more cognitive issues can play a role. Ultimately, I think the biggest thing that I would stress this evening, and that you'll hear me repeat several times, is the care that's provided, whether it's from a therapist, from an athletic trainer, for any other healthcare provider that's helping these athletes return, is that it needs to be individualized to each patient's presentation. And we'll speak further about kind of some of those different buckets, like Dr. Tucker mentioned, and some of the areas of what I like to classify them as. Here we have kind of a similar return to sport program. It's adapted from May and Halstead, but you can see it mentions that it should take approximately 24 hours to advance. We're going to rest for a day or two, and then we're going to initiate some light aerobic exercise, and we'll discuss kind of some safe and appropriate aerobic training with some of these patients. If they're able to continue to advance through safely, we're going to move into some sport-specific exercises, non-contact. We're going to limit anything. So this may include some light running with dribbling a ball, such as in soccer. This may include some skating drills, but just beginning to add kind of a light movement patterns to them and determining that their response. After that, we're going to advance towards some non-contact training, so adding more complex areas such as passing. This may include route running with our football athletes, and ultimately potentially some light resistance training with these athletes. It's appropriate at this time frame as long as they're continuing to move forward positively. And you can see in that kind of the objective of that area is to kind of progress the exercise, progress the patient coordination, and to advance the potential cognitive load and determine their response. So in step 5, if we've been able to move forward safely, we want to look at a potential full contact clearance or full contact practice, following medical clearance with some of those activities, and make sure that the patient is confident in their abilities, and make sure that they're able to kind of tolerate the environment that they're going to be participating in. And then finally, a successful return will be kind of returning to normal game play and full return to pre-concussive activities. As mentioned, the majority of these patients typically are going to recover within approximately 4 weeks. Some of the numbers that I've seen in some of the data is, approximately 80 to 85% of these athletes will return. These patients may not need therapy. They may just be able to utilize a return to sport program with their athletic trainer, and then maybe therapy is utilized kind of as needed. However, if 80 to 85% recover within that kind of 4-week time period or 7 to 14 day time period in the adults, that's still leaving about 15 to 20% of patients who are going to have kind of a delayed recovery time. So, the big important question is how can we identify these patients, whether that is trying to catch them immediately with, potentially preseason baseline, testing to determine anyone who may have some kind of increased risk factors. And then from there, kind of once we've identified them, how can we treat them? And the literature is beginning to get a little more established, but there's nothing hard and fast that says, such as with a ACL repair or a UCL repair, we have a hard protocol to follow. With these concussive patients, it's got to be individualized, and hopefully we're going to be able to advance through successfully. Like Dr. Tucker mentioned, I tend to break them into kind of 3 categories of potential patients. And I think you could make a strong justification to separate out the vestibular and ocular into separate ones. But, a physiological classification is going to be looking at kind of exertional tolerance. So, how can these patients kind of begin tolerating activity in more of an aerobic capacity? Some of these patients present more with a cervicogenic classification, that they typically present with more cervical spine impairments, upper thoracic spine impairments from a mobility standpoint, and some typically impaired movement patterns. And then finally, the vestibular and ocular classification, which typically is going to have more, nausea, dizziness, and looking at some of those patients. I think what some of the kind of the best amount of literature right now is really supporting a lot of subsymptom threshold aerobic exercise. I think Del Rossi in the Journal of Athletic Training and Harris from HSS up in New York, they had a good study, I believe a year or two ago, that looked at how subsymptom aerobic exercise can help correct the impairments of local blood flow, and to look at assisting with reestablishing normal control of the cerebral blood flow into the brain. It's important to kind of, similar to the return to sport program, if I'm having a patient here in the clinic, I'm going to look at a progressive gradual return to exercise. It's important to establish kind of what is the level that the athlete can tolerate without having symptoms, and then beginning an appropriate training program to advance it. And some of the literature shows that, working at 5 times a week for 20 to 30 minutes for 8 to 12 weeks shows great return. I think that can be sped up, but ultimately it's up to the athlete's presentation and us as healthcare providers to make sure that we're providing safe and appropriate exercises for them. An effective target heart rate is approximately 80% of when the symptoms occur, and those can be assessed utilizing the Buffalo treadmill test is one of the kind of best researched and best studied test that shows good applications with this population. There's some groups here in Birmingham that will want all of their concussive patients tested with the Buffalo treadmill test, and it's designed to assess the patient response to exercise. It can be useful in a post-concussive patients who may be classified as post-concussive syndrome, as well as cervicogenic and vestibular ocular if they're able to tolerate that. And then you can look at which variables can cause the increase in symptoms. So ultimately, the patient is utilized, the Buffalo treadmill test is utilized on a treadmill. It begins at either 3.2 or 3.6 miles per hour, depending on if you have the option to utilize an incline. And then as the patient begins going, we're utilizing the visual analog scale, as well as attempting to take heart rate and blood pressure. Earlier in my career, this was a little more challenging test to implement. You typically needed 2 to 3 individuals, a combination of therapists or athletic trainers in there, to be able to monitor the patient, provide the visual scale kind of as they were going through each minute, and then ultimately taking kind of blood pressure and heart rate as they were going through. With some of the apps that have been designed, that helps us. There are some margins of error within there, but it definitely has made it more effective to implement it into a single clinician setting, or if you just have that kind of out at a school and an athletic trainer can take them through. Ultimately, that treadmill is inclined to a max of 15 degrees, kind of goes up 1 degree per minute as long as the patient is able to tolerate and does not want to cancel the test. And once the max incline is reached, the speed of the treadmill will begin to increase as well. If the patient's able to make it through that 20-minute test, we can take their heart rate and able to utilize the scale to kind of create an 80% max heart rate training program, and some cardio training can be utilized. That may include swimming or walking or cycling, or ultimately just continuing to use the treadmill. As it relates to cervicogenic treatment in these patients, typically I look at a lot of manual interventions, including joint mobilization techniques, as well as soft tissue and myofascial manipulation techniques. Within the cervical thoracic spine, I think it's important to address restrictions within the subcranial spine or the upper cervical spine at C1 and C2, and then beginning to kind of perform an appropriate evaluation with these patients, looking at the mid-cervical spine, and then assessing the thoracic spine and mobility. In addition, we want to look at retraining them utilizing joint repositioning and accuracy techniques. And in some future slides, we'll look at some specific exercises. And then ultimately want to reestablish kind of effective motor patterns for these patients to return back to their sport. When we look at specific mobilizations or specific therapeutic interventions, when it comes to my manual interventions, I think a subcranial inhibition or a manual cervical distraction is one of the kind of easiest and simplest techniques to, one, gain these patients' trust as we hopefully are able to advance them through. It's a great technique at helping to reduce headaches, looking at reducing tension within the suboccipital musculature, and kind of beginning to relax the paraspinals. Other techniques would include kind of manual upslide or downslide techniques to the cervical spine, and then looking at specific interventions to the thoracic spine, such as a forward press to the upper thoracic spine and rotational mobilizations to the same area. I've also had some good success as the patient moves forward into their program and as they advance to kind of those final steps, incorporating PA mobilization in the thoracic spine, and often including kind of a grade 5 thrust mobilization. Additionally, these cervicogenic patients typically present with other issues such as soft tissue or muscular restrictions. Typically, the SCOM or the scalenes are impaired, as well as potential tension within the upper trapezius sign. This may include kind of hands-on massage. This may also include utilizing modalities with these patients to kind of help reduce their acuteness of the severity of the injury. And then depending on their tolerance, some success has been had with kind of instrument-assisted soft tissue manipulation. However, I think a lot more research needs to be performed, and I definitely stress caution of when the timing is utilized for those techniques. Within the cervical spine, I think one of the most important areas of exercise or muscles to address is going to be your cervical stabilizers, your longus capitis and coli. This can be trained in a variety of positions and postures, and then ultimately, as we'll see, utilizing that with kind of other movement patterns and kind of making the this appropriate positioning for the neck kind of their more natural state. Other muscles to address would include your scapular stabilizing muscles and kind of in combination with that chin tuck and being able to kind of provide if we look at from the lumbar spine perspective of that kind of proximal stability to create distal mobility, I think the same concept applies in the cervical spine and with these concussive patients. Specific exercises may include utilizing a kind of upper body throwers 10 program to strengthen the rotator cuff and the scapular muscles. Lower extremity programs can be utilized as well as the patient advances through. I think probably the most important aspect is tactile cueing of the therapist to improve the cervical positioning and to make sure that these athletes are kind of performing these exercises correctly, and that we're not causing them to move inappropriately, thereby causing an increase in their symptoms. As they advance through the program, it's, I think, very important to challenge the patient by incorporating higher level processing tasks. This may include dual task activities where they're working on ladder footwork agility drills while questions are being asked to them or balls are being tossed, and utilizing kind of other external objects as needed. Other specific exercises, which again, the literature is beginning to kind of look at what is most effective. And with this in the cervicogenic patients, they tend to respond well with additional core strengthening. This may include planks in a frontal plane or a lateral plane, single leg bridges, double leg bridges, as well as training in the quadruped and the bug positions. I'd like to utilize some of the Watkins protocol from Dr. Watkins out in California for his spine post-surgical patients, but I've had some good success utilizing that with my some of these patients as well to challenge them, and then ultimately working on their neck positioning. We see the individual sitting on the ball not only is working on postural and kind of trunk stability, but if you look closely at his head and then forward onto the wall, he's got a laser on where he's working on that stabilization and then being able to control that laser with that immediate visual feedback. Sometimes we'll look at having these athletes kind of perform a circle or track a pattern, but ultimately it's teaching them to be able to maintain that stabilization pattern throughout their daily task. Finally, when we look at the vestibular and ocular patients, Benson and a program with the NHL found that dizziness was kind of the second most common symptom following a concussion. Schneider and Bara Al-Salihin have found in multiple studies going all the way back to 2010, and then there's more recent stuff from 14 as well as some studies from 2019 and 20 that have found positive effects on recovery utilizing vestibular rehabilitation with concussion, so balance training, and they've found that this has had a positive return to sport than just standard therapy. Depending on these vestibular patients' limitations, it's important for the therapist or the trainer to potentially be familiar with the Hallpike-Dix or the Epley's maneuver and kind of identifying the appropriate direction and location for this technique, depending on what these patients are complaining of and what certain positions cause that. Ultimately, some individually targeted exercises are important. We want to facilitate any potential compensations in the sensory and motor units, as well as look at addressing any potential adaptation or habituation or substitution patterns that these athletes had developed since their injury. I find that balance training is key with them, and we'll look at that in the slide following this one. I believe Dr. Tucker, Dr. Joya had mentioned look at some of these specific patterns to be utilized in the clinical setting. I think they can also be, from an assessment standpoint, I think they can also be utilized effectively from a treatment perspective, whether we're looking at saccadic movements where the head is still and we're looking at the eye tracking an object, or gaze stabilization strategies where there's a stationary target and the head is then moving. There's also some fairly effective apps on the App Store called Numbers and FitBrains that can be utilized to assist with some of these patients. As mentioned, balance training is key. I think utilizing BOSU foams as the patient tolerates is important. We're going to initiate this training in a double leg positioning, typically with a narrow base of support, and ultimately progressing to single leg, starting with a static test, and then ultimately progressing to dynamic training. As mentioned, some of those unstable surfaces, such as a foam or a BOSU or a wobble board, are excellent at providing some of the feedback. And then there's some other outside objects that can be utilized. The individual with the glasses on is kind of working on some visual retraining techniques. I would caution that anyone with a history of seizures needs to be limited with those activities. And then in the bottom right corner of the screen is an item called Hiko sticks. You can look at tossing these back and forth to an athlete while they're training and having them make sure that they're grasping, providing a verbal cue for them to grab the right handle. Ultimately, I think the biggest thing is the treatment for these athletes needs to be individualized, whether we're looking at a physiological concussion patient, a cervicogenic patient, or one that may be complaining of more vestibular ocular complaints. Typically I find that some of these patients, I think how Dr. Tucker mentioned that they kind of come out of each bucket. And so often I'm going to see a patient who has some physiological deficits as well as some cervicogenic deficits, and a combination of kind of strengthening and manual interventions in addition to the cardiac training tends to kind of provide at least from what we found here in Birmingham, kind of a positive outcome. It's important to educate the patient that it's key to advance symptom-free through the return to play or return to school program. It's also important to look at the environmental characteristics. Your cross-country runner who suffered a concussion not in the field of competition, but say in a car accident, obviously is going to have more of a challenge than our basketball, or less of a challenge, than our basketball player or football player who's going to be dealing with a more contact sport. Ultimately, and I think here in Birmingham, what brought me here was a close relationship with these physicians. I feel very fortunate to be able to get a hold of Dr. Ortega immediately if I have a question about a patient. So it's important to have clear discussion with not only the patient and the family, but as well as the physician, the athletic trainer, and any coaching or school staff as applicable to potential look at any accommodations that are needed, but as well as making sure everyone on the same team kind of understands what the proper response is to hopefully get these athletes back to the field of play, one, safely, and two, as quickly as possible, because we know all athletes want to be playing. They don't want to be limited on the sideline, but it's ultimately up to us as healthcare providers to kind of do that in a safe manner. So I want to thank you all very much for your time. Obviously feel free to reach out if there are any questions, either here directly, or I'd be more than happy to take any questions that are here now. So again, thank you to ASMI for the opportunity to be here this evening.
All right, thanks everybody, both Andy and Andrew, and then Jerry for your talks. We do have couple questions. One comes from one of our former fellows out there in the audience. So the question is, if most athletes recover within 1 to 2 weeks, when do you recommend sending a patient for concussion therapy? So I guess that would apply to either Andrew or Tucker or Andrew Hutchison. What's your your protocol, your thoughts on when to send somebody for concussion therapy?
I think a lot of it, if they're not showing improvement within 48 to 72 hours, after that kind of initial rest, and if they haven't seen a physician like yourself or a physician like Dr. Tucker, I think kind of immediately getting with them is kind of most important. I've had good success with mainly with the cervicogenic patients, getting them in earlier. I've had patients within 72 hours of a concussion that come in. I think the biggest thing with the more acute patients is from a clinical setting is making sure that we're getting them in a quiet environment. We're not bringing them into a busy clinic where we're going to potentially exacerbate some of their symptoms just to begin therapy or begin some of that process. So for me, I think I feel comfortable kind of working as quickly as a physician feels comfortable kind of providing that referral, whether that's within that 1 to 2 week time frame, or if we want to wait until maybe that more post-concussive syndrome is kind of officially classified at that post 4 weeks. And obviously, Dr. Tucker, feel free to kind of add any expertise that you may have here.
Yeah, I agree, Andrew. I think it depends on just the clinical picture. If there's a lot of cervical dysfunction or a lot of vestibular or ocular dysfunction right out of the gate, I think that patient benefits from seeing somebody like you very quickly, early on. If it's more sort of non-specific, generalized symptoms, we'll just let them sort of get better on their own and then start the return to activity protocol. So it really depends on which domain I think is most dysfunctional. Dr. Andrews?
Yeah, the thing that comes to mind that I keep hearing about is, maybe we've got some real experts here, but who does the final medical release for return to competition or sports or whatever after a concussion? Who signs the paper to allow them to go back, or how does that work now? Because I've heard there's some territorial disputes between the different groups about who does that.
Depends on what league you're working with, I guess. If we're working with the Ravens, then I give my blessing to the recovering athlete, but the collectively bargained agreement says that Dr. Joya has to sign off, and then the independent neurologic consultant has to sign off. So it's a process. If we're talking about collegiate and high school athletes, I think the team physician probably still has the lead role in determining the clearance, but I consider it sort of a group or decision by committee, oftentimes utilizing people like Jerry if he's involved, and the athletic trainer or the physical therapist. But I think the team physician ultimately has that call.
Yeah, let me just add too, I agree, Andy, that states have different sort of guidance on that, and it probably in part is how well your profession lobbied to be part of that that decision. But ultimately, because this injury is a multi-system injury, you really need multiple inputs, and regardless of who that final decision maker is, it's so critical. So if I'm seeing somebody, I want to make sure that they've either seen their pediatrician, sports medicine, whether they're a prolonged injury. I absolutely want to know from their physical therapist how they're doing. So it has to be that combined piece here, from my perspective. But I think most of the time when it's a fairly, if we want to call it typical or rapid recovery, at least in the youth world, it's the primary care physician that's making that decision.
It seems to me
I'll say-
like that there ought to be a close relationship, and it's a team effort to treat somebody with a concussion. That's what we've seen tonight. So it seems to me like, for example, that the medical doctor and the neuropsychologist should both be able to come to agreement that this kid's cleared.
Yeah.
And that's the ideal situation, but I've seen it not go that way, and so it worries me.
Yeah, I'll say the way I do it, and here I think Andrew Hutchinson said it here in Alabama. The state laws, the player, the high school kid, and the college kid have to be cleared by a physician. It doesn't specify whether it's their family doctor or sports medicine physician. But the way I operate in my practice is I follow the kid until they become asymptomatic, and then once they become asymptomatic, I let them start that formal protocol with the athletic trainer at school, and I'm keeping in touch with the athletic trainer, making sure that they're progressing normally and not having any recurring symptoms. And that's for the straightforward kids that don't have any problems. If they're having prolonged recovery and need a neuropsychologist or even a physical therapist, yeah, I'm collaborating with everybody to, come together and decide how we're going to progress this kid and when they're good to go back. And the neuropsychologist I use here in Birmingham, he always says, I don't clear anybody to go back to sport. That's the doctor's job. I'm just reporting what I'm finding and what I'm recommending as far as accommodations and so forth from a neuropsych standpoint. So, okay. So one other question, what are your thoughts on supplements such as fish oil for the inflammation post-concussion?
Well, that's an easy question. Certainly lots of supplements utilized. And there's a lot of support out there. I don't routinely promote that amongst my collegiate or high school athletes or even my professional athletes. I don't think it does any harm. I'm not convinced that it clearly shows a benefit. But I certainly get that question a lot from parents and so forth, trying to speed up the recovery. No different than a musculoskeletal injury. I'm just not convinced that it makes much difference.
Fish oil or snake oil?
A little bit of both.
A little bit of both.
I do have a question for Andy Tucker. So what's your thoughts, the new biomarkers that are being reported that are being used in assessment of head injury? How does that relate to concussions?
Yeah, I think things like blood tests or saliva tests are fascinating technologies regarding potential real-time diagnosis modalities or technologies rather. I still think it's should be considered certainly more on the research realm still, and it's certainly not evolved in my arena to be something that's practical or usable yet. But I think it's fascinating technology, and perhaps when Jerry's working on the next international concussion conference, there'll be some more data presented at that time regarding some of the biomarkers.
Actually, let me just say, so NINDS put out a big grant, a center grant, a U grant, a multi-center grant that our research group called the Four Corners Consortium applied for. You're not hearing me tell you this, but we believe we received it, and it's with UCLA, with Chris Giza, Dave Havda, with University of Washington, with Wake Forest, with UT Southwestern, and with Jeff Bazarian up at Rochester. What we're doing is we actually have a blood biomarker core, we have a neuroimaging core, then we have an autonomic core. And the purpose of the grant is actually to identify as what we're calling endophenotypes that will really be predictive models for whether you are going to fall into that the persistent post-concussive symptom group. We don't actually use the syndrome word, we call it persistent post-concussive symptoms, which is going to be defined as 12 weeks out. Now, we actually have some models for 4 weeks, for 8 weeks, and for 12 weeks too. But the big study in kids was done in Canada, published in 2016, and found that the algorithm that they had developed was about 70% accurate in defining whether you're going to take 4 weeks or longer. And basically, what NIH is saying, can we do better than that? Can we add, some of the biological markers, whether it's imaging, blood, or some autonomic? Actually, we're doing some ocular kinds of things, some other kinds of tests. And so that's a 5-year grant, and we fully expect that we will have a better algorithm that will come out with which of these markers. Jeff Bazarian is expert in this area in the blood biomarkers, and the USC group that, believe it or not, works with UCLA, which is a remarkable thing, is the neuroimaging center that's going to be looking at this, and then the whole autonomic group. So I think in the next 5 years, we're going to be learning about what combination of factors, and this is meant to be a practical biomarker panel. This is not meant to be, somebody that's got to have some, functional MRI or some other kind. It's really going to be a practical kind of tool that, could be used. And that's actually what the reviewers lauded us on with our application, was that this actually looks like it could be usable. So anyways, it's, to be continued. And again, you didn't hear from me, but I think we may have that.
Jerry?
Yeah.
Can I ask you another question that's, I think is, I don't know the answer to it, but you're involved with the pediatric concussion group. What do we do about youth coaches that are unpaid, coaching kids 14 years of age and younger, that have no formal training in recognition of sports injuries, particularly concussions? What do we do about, and usually they're the only ones there when this happens, for example.
Right.
None of us are there. Nobody on this type of panel is there. What do we do about that type of recognition problem by youth coaches?
Well,
How do we solve that problem?
Well, so back in 2003, when I first started working with the CDC, and they put out their high school toolkit, we just said, so we've been working with the CDC around their whole Heads Up program and what can we do to educate. We've got elements in these state laws that say you've got to be teaching this. We can improve upon that. I'll be honest with you. I really think it's ultimately going to be the parent advocacy group to make sure that their coaches are, being trained. As we know, it's a tricky proposition. Moms and dads sign up to be their kid's coach. They don't sign up to do, get 10 hours of medical training, and so and yet a lot of them want to know that, and some of them don't have the time for it. And so I know these youth organizations are very concerned about whether they're going to be scaring away their coaching population or not. But I think we've just got to be more focused on this. I actually think we can teach people how to do this. And, again, there's a couple of different things going on right now. A study, again, out of the University of Washington and Seattle Children's, that's looking at a model in which the coach and the kids have this little huddle beforehand, and they remind each other of what those things are they need to be looking for. And so it sort of gets them into the mindset of this. It's got to be scalable. And we developed a smartphone app that's for parents and coaches, something, that, they have in their pocket that they could at least do some recognition and response around. It's got to be a big focus. Years ago, when we were rolling out the Heads Up program through USA Football, and Roger Goodell and I were at this, we're talking to a group of parents basically about, what was going on in the world of concussion. And Goodell actually had a really great statement. He said, how many of you people would ever bring your kid to a babysitter without doing probably 5 background checks on these people. You're not going to drop off your kid to somebody, that you don't know about. You should be doing the same thing with your sports organizations. You need to make sure that they are prepared, that the coaches are taught what they need to be taught. They're playing the game and coaching the game the right kind of way. And I think that's a good model, that, the parents got to make sure that they're sending their kids to a place that coaching organization is prepared.
This was somewhat of a loaded question. I don't know if you know it or not, but in the state of Alabama, it's a state law that we finally got passed that all youth coaches coaching kids 14 years of age and younger have to be accredited. And they have to take a test on recognition of
Right.
youth sports injuries. It's called it's the Coach Safely Foundation, for example. And at least it's a start. The big problem is these youth coaches, who are usually dads, so they're my son-in-laws, for example, they have no idea about the liability they have in coaching these kids in youth sports and not knowing how to recognize even the basic type of injuries, particularly a concussion. So we're trying to get that done now in all 50 states.
Yes.
It's going to be a big deal to do it, but at least they should be accredited, and they take a test on the internet, which is free. They have to take a retest each year to coach. By the way, there's 70,000 or so youth coaches in this category, and just in the state of Alabama, for example.
Who's heading up that program? Is it the coach?
Jack Crow and myself.
Yeah, Jack Crow. Sure, I know Jack, and Jack and I work
Yeah,
together.
I know you knew Jack.
Yeah.
Jack is a coach, and he's
Right.
trying to figure out how to teach coaches.
Yeah. No, it's a challenge, and I think we can't stop pushing ahead.
Well, thank you. Help us with that.
Actually, Jack sent me a note. I think it was last year, pre-pandemic. Every year he seems to update me on what he's doing. I had forgotten his name because it's been a while with all this, but no, it's good work. He's doing
It's got
some really
traction, but we need the help from everybody on this panel, for example.
great.
And I got one final question, if there's anything else from the audience. So to Dr. Tucker, what's your criteria for disqualifying somebody permanently from sport due to concussions?
Yeah, that's an easy question too, Jody. Thanks for the easiest for last. It's an individualized decision. I often tell parents there's no magic number. If one high schooler has had a horribly complicated recovery for a single concussion, then that's taken them months and months and months to get better. I'm reluctant to clear that young athlete again. On the other hand, if you've got a handful of concussions that have been spread out time-wise over a long period of time, and they were characterized by low symptom burden and a quick recovery and an uncomplicated recovery, and no apparent sequelae in the context of no comorbidities and so on and so forth, then I certainly have returned athletes back to play and allowed athletes to continue to play with 3 or 4 or 5 concussions probably documented over their grade school, high school, and college career. They asked me, you could ask the tough question, is are they at increased risk for something down the road? And I really have to honestly say I don't know. I think the chronic traumatic encephalopathy issue, which is not going to be completely understood and not going to be not going to be something that we can tease out here in our last minute, but I think those folks that do struggle, and I do think it's a small percentage, is probably the people at risk is as much or more likely to be those with lots of subconcussive blows as compared to the actual number of concussions, and I think there's some data to support that. But it's an individualized decision, and it's a hard one.
Definitely. Okay.
I would
Doesn't
say-
like we have any other questions
Jody,
from Jerry.
One piece I would add to what Andy's saying here is that, and Andy and I have shared a couple cases along the way with that kind of question. We certainly with college, high school, and below, I mean, we will do some pretty in-depth neuropsychological testing to make sure that cognitively they're doing well, their school performance is maintaining. There's no other social or emotional kinds of issues that don't have another etiology. So that's definitely a question that oftentimes requires a few of us to, take a look at, just to make sure that we're covering all the bases. And in this day and age, a lot of parents are asking those questions. And I would say more times than not, we're able to relieve their anxiety that their kid seems to be doing just fine, but they're asking good questions, and that's what you want to know, that my son or daughter is not, in some higher risk category or manifesting some impairment, based on their injury history. So I think it's a difficult, but oftentimes requires a little bit of input from several of us to help answer it.
For sure. Doesn't look like we have any other questions, so I'll thank all our speakers for participating tonight, as well as everybody that participated from the virtual side attending. I'll throw it back to Dr. Andrews for any last comments before we adjourn.
Now, this is I've tried to stay as far away from concussions as I possibly can, but programs like tonight really got my interest, and I've been sitting here listening to everything, and sooner or later I might learn something about concussion. So we certainly appreciate the expertise tonight. I know you've stimulated myself, you've stimulated a lot of people that are involved on this program tonight in this webinar. So it was well worth y'all's time. Webinars are really great because we're able to sit here at home, concentrate, listen, not get interrupted. At least my dog hadn't interrupted y'all tonight, but he's been up here nudging me in the last few minutes to let him out. So I'm out of here. Thank y'all for everything you did tonight. I appreciate you very much. Andy, thank you here. Good to
Thank
see
you, Dr. Andrews.
See
Good to see
everybody.
you.
Y'all got to win that Super Bowl now.
We'll try. We'll try.
All right.
Thank
All
you.
right. Good luck.
Take care now.
Thank-
Bye-bye.
Take
Thank
care.
you.
Bye-bye.
Thank you. Thank you very much, Jerry.
My pleasure.
And Andrew, you too, man.
Thank you, sir. Great to be here.